So today the topic is on the physiology of pregnancy, and specifically we are going to look at the systemic changes which occur in the woman when she's pregnant. Now, these are positive physiological changes which occur to help the mother accommodate and support the fetus throughout pregnancy. And so we are going to pick the various systems and see what occur in them. Now, in the endocrine system, we are going to look at it in terms of the changes in the pituitary gland as well as the ovaries and placenta. Then we shall look at the thyroid gland and the adrenal gland. And so we realize that there is an increase in the size of the pituitary gland, and this is due to increased blood supply. And because of this, anytime there is excessive bleeding intrapartum or even postpartum, it may cause ischemia to the pituitary gland, and the condition that we call Sheehan's syndrome may occur in the woman. Now we realize that the prolactin levels increases by the 5th week of gestation, and this aid development of the mammary ducts and also help to establish breastfeeding. The prolactin also inhibits ovulation, and this explains the reason why breastfeeding mothers do not get their period. Now, the levels of the prolactin increases during pregnancy, but the levels decreases after delivery. But later on, when the baby begins to suckle, we get increasing levels of prolactin occurring once again. Now, the corticotropin releasing hormone from the hypothalamus stimulates the production of the mother's adrenal corticotropin hormone as well as cortisol. And the presence of adrenal corticotropin hormone and cortisol leads to the increase in maternal cortisol levels in the 3rd trimester. And this is very necessary for fetal lung maturation. And also it leads to greater concentration of glucose available in maternal bloodstream for fetal consumption. Now, when we look at follicle stimulating hormone and luteinizing hormone as well as even the thyroid stimulating hormone, we realize that their function even decreases because their role in pregnancy is quite limited. Now, the placenta produces the HCG, and this HCG doubles approximately every 48 hours during the early pregnancy, and it reaches its peak by the 10th to the 12th week of gestation and begin to decline to a steady state after the 15th week of gestation. Now, this HCG is the one which acts to maintain the corpus luteum in early pregnancy. And so we need the corpus luteum because it produces progesterone, and this progesterone maintains the endometrium during pregnancy. Now, eventually, the placenta develops and takes over the production of progesterone, and the corpus luteum eventually, degrades into the corpus albicans. And so the progesterone levels in pregnancy increases throughout the course of pregnancy. What about estrogen? The major estrogen in pregnancy is called the estriol, and it increases as well. And so we say pregnancy is a hyperestrogenic state. Now, the increased estrogen is primarily produced by the placenta, and we have very little coming from the ovaries. Then we also have an increase in what we call the human placental lactogen. This is produced in the placenta, and the function of this is very simple. It ensures that there is a constant supply of nutrients to the fetus. Now, the human placenta lactogen, what it does is it breaks down fat to be used as another source of energy for the fetus. It also inhibits insulin. So as it inhibits insulin, it causes a diabetogenic effect in the mother. And this rather leads to increased levels of insulin and protein synthesis, as well as serum glucose for the fetus to use. So this is what happens in the ovaries and the placenta. Now, when we look at the thyroid gland, we realize that the thyroxine is essential for the fetus neural development. So the neural development of the fetus, is very essential, and so we need thyroxine levels to increase. But during pregnancy and the early stages of pregnancy, we realize that the fetal thyroid gland is not functional until the second trimester, and so increasing T3 and T4 levels in the mother ensures that there is a constant supply of thyroxine to the fetus in the early pregnancy. And so we also realize that estrogen stimulates the thyroid binding globulin to increase, and this leads to elevation in T3 and T4 in the mother. So that is the total T3 and T4 are elevated in the mother, but the free T3 and T4 remain relatively constant. And so overall, we say pregnancy is, an euthyroid state, and this is because of the increase in the thyroid, binding globulins. Now, in the adrenal gland, we find that there is increasing levels of cortisol, which I explained earlier on, and this is because there is increase in the levels of maternal adrenocorticotropin hormone, which causes the increase in the cortisol. We also find that there is going to be increase in aldosterone, and this is together with serum angiotensin 2. And so the increase in the serum angiotensin 2 and aldosterone levels contribute to sodium and water retention, which is required for the volume expansion in pregnancy. Then we also find that the corticosteroid binding globulin also increases. And so these are the changes which occur in the endocrine system. Now, in the musculoskeletal system and the skin, we find certain changes. Most of them are within the skin, and we find that there is what we call spider angiomata and palmar erythema. So this one being the spider angiomata is the dilatation of smaller blood vessels under the dermis, and this is the palmar erythema, and the erythema is prominent at the thana eminence. Then on the nipples and the umbilicus, we find certain changes. So we can see that the nipples become erect and enlarged, and also there is the appearance of the secondary areola with the Montgomery's tubercle. So these small nodules over here are the Montgomery's tubercle, and they are basically sebaceous glands. Now, we also have some changes on the abdomen, which we call the linea nigra, which is the black line of pregnancy. It stretches from the symphysis pubis to the upper part of the abdomen, as you can see. Then we also have the striae gravidarum, which is also referred to as the stretch marks of pregnancy. And the linea nigra is as a result of increased deposition of melanocyte stimulating hormone. Then we also see as a result of the increased deposition of the melanocyte stimulating hormone, we get the hyperpigmentation in almost all over the body. And so when it's found on the face, sometimes on the cheek and also on the forehead and also on the nose, we call it the melasma or the chloasma. So these are the changes we find in the skin. Pregnancy is also associated with carpal tunnel syndrome, and this results from compression of the median nerve in pregnancy. But the symptoms are usually self-limiting. Also, the women may complain of a shift in their posture, which is usually seen as a lower back pain. It, however, gets worsened as the pregnancy advances. Now, what about the metabolic changes in pregnancy? Now, we know that in pregnancy, the basal metabolic rate increases by 10 to 20%. Also, there is increase in water retention, partly due to the decreased plasma osmolality. as we've seen. And so edema may sometimes be normal in pregnancy. However, when the edema is present with high blood pressure and proteinuria, your attention should be drawn to, preeclampsia. Now, in pregnancy, protein metabolism is enhanced to supply substrates for maternal and fetal growth. We also see that fat metabolism increases, and this is evidenced by the elevation in all lipid fractions in the blood. Then also we see that carbohydrates has the most dramatic changes in pregnancy. So the levels of carbohydrate increases. Now, an important thing we need to know over here is that the optimal blood glucose in pregnancy is 4.4 and 5.5. So 4.4 millimole per liter to 5.5 millimole per liter. Now, whereas in a non-pregnant woman, signs of hypoglycemia begins when the glucose level is 2.2 millimole per liter. In the pregnant woman, a glucose level below 3.3 millimole per liter is considered hypoglycemia, and so we should pay attention to this. And so the diabetogenic effect of pregnancy is the normal physiological adaptation, which requires that there is a shift of the maternal energy source from carbohydrate to fat. And so the so-called diabetogenic effect of pregnancy is a normal physiological adaptation, which requires that there is a shift in maternal energy source from carbohydrate to fat. And so by using the fat stores which were laid down in the first trimester as the primary energy source, glucose is then spared for the growing fetus. And so as the nutritional demands of the fetus increases in the second trimester, together with, if you remember, we said there is insulin resistance, then fat storage decreases as it's mobilized to provide the mother with extra energy supplies. So this is some of the metabolic changes that happens in pregnancy. Now, the nutritional requirement increases during pregnancy and breastfeeding, and so an average woman requires about 2,000 to 2,500 kilocal per day. In addition to the increased caloric requirements, there are increased nutritional requirements for both protein, iron, folate, calcium, and other vitamins and minerals in general. And so the protein requirement increases from 60 to 70 or 75 grams per day, and the recommended calcium intake is about 1.5 grams per day. Now we realize that many patients develop iron deficiency anemia because of the increased demand on hematopoiesis, both for the mother and the fetus. And so folate requirement increases from 0.4 to 0.8 milligram per day. And this is very important in preventing neural tube defect. We, however, sometimes even recommend that even before the woman conceives, whilst the woman is planning to conceive, the woman can start taking this folate or folic acid and continue with it throughout pregnancy. Now, all pregnant women are advised to take prenatal vitamins during pregnancy, and these are designed to compensate for the increased nutritional demands in pregnancy, which may not be readily available in the food we eat. And so iron requirement increases due to the increase in red blood cell count. Furthermore, any patient whose hematocrit falls during pregnancy is advised to increase iron intake with oral supplementation. And this is because the most common cause of anemia in pregnancy is iron deficiency anemia, and so we must guard against that. Now, in terms of nutrition, I want to give a very simple advice on fasting. Now, it is not recommended for pregnant women to fast, skip meals, or even restrict carbohydrate intake. This is because maternal blood glucose levels are critically important for fetal well-being. And so, prolonged fasting in pregnancy may lead to ketone production, which may be dangerous to the fetus. Now, although Muslim women are exempted from fasting whilst pregnant, those who wish to fast during Ramadan may do so under medical supervision if it occurs, especially in the second trimester. Now, fasting during the first and the third trimester are, however, not recommended. This is because of the possible dangers to the fetus from dehydration. Rather from malnutrition, it has got nothing to do with malnutrition. The danger to the fetus in these trimesters is dehydration. This is why it is not recommended that in the first and third trimesters of pregnancy, you shouldn't fast. Now, interestingly, fasting during Ramadan has been shown not to affect the mean birth weight of babies at any stage of pregnancy. And so mothers may report less fetal movement, during the day. But this is, compensated for by, increased activity at night as, the fetal diurnal cycle changes with that of the mother. And so the take home, from this slide is that we need to increase the nutritional requirements, especially the proteins, the calcium, the folate, and the iron. And we also need to guard against fasting. And if a Muslim woman wants to fast, then it is best done in the second trimester of pregnancy. So let's finish up with the changes in the breast and the reproductive tract. Now, as we've seen, there is a rise in estrogen levels, and this helps to stimulate the growth of the mammary duct, and also the progesterone levels increases to help cause alveolar hypertrophy, and so the two come together to prepare the breast for lactation. Then we realize that towards the end of pregnancy and also in the early preperium, the breast produces colostrum, which is the thick yellow secretions, which is rich in immunoglobulins. And these yellow secretion is not just rich in immunoglobulins, it is also rich in antibodies and antioxidants, and it helps to build the newborn baby's immune system. And so within 2 to 4 days, it changes from colostrum to the breast milk. Now, with the vagina, we realize that there is, increase in the thickness of the vaginal epithelium, and this is because there is increased, blood supply to the area. Then also we have the cervix becoming swollen and, softens. As we've seen, we talked about the signs of pregnancy, and so the cervix gets swollen and softens. And sometimes, because of the increased blood supply to the vagina and the cervix in pregnancy, in early pregnancy, the woman may experience spotting, some blood during sexual intercourse, which may be normal, not to cause any alarm. Then also, we also see in the uterus that in early pregnancy, the uterine growth is due to hyperplasia and hypertrophy from the activity of estrogen. Now, as pregnancy advances, the hyperplasia reduces, but the hypertrophy becomes very high, and so we get changes in the weight of the uterus. Not just the weight, the size also changes, and so we are going to have the weight of the uterus increasing from 60 grams prior to pregnancy to about 1,000 grams at term. And also, we realize that the endometrium of the uterus changes its name, and so after the embedding of the blastocyst, there is the thickening and increased vascularity of the inner layer of the of the endometrium or of the uterus, and this is now called the decidua. Before pregnancy, it was endometrium, but in pregnancy, it becomes known as the decidua. And so, decidualization is marked in the fundus and upper part of the uterus. Normally, that's the site for implantation. I think this is all that I have for you. Thank you very much for your attention. Bye bye.